The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Everybody, welcome back. In this podcast, we're going to look at warm fluids in resuscitation. I think the important part about thinking broad in resuscitation is to always reflect on where you're at currently in the time of year, right? Right now, we're in the summer months, and it's really easy to forget that even though it is hot outside, you're sweating your butt off, you're working your tail off, that these patients, regardless of ambient temperatures that might exceed 110, 120 in some areas of the U.S., that these patients are delivered every single day hypothermic. How does that happen? So let's jump in and talk about damage control resuscitation. Let's look at hypothermia in resuscitation. How does that happen? And then highlight some ways we can make sure that fluid warming is a priority. Let's start off with a little backstory, a little history. Let's look at the amount of patients that every day are susceptible to hypothermia. Traumatic injuries, we know, are the third leading cause of death in all age groups across all lifespans, but actually the leading cause of death of anybody under the age of 44. It's interesting, though, more Americans under the age of 34 die from unintentional injuries. And I think that makes sense, right? We are usually younger, we're healthier, but we are out there, we're doing our own thing, we're enjoying ourselves on vacations, doing recreational sports, doing recreational activities, and things happen. More than half of all deaths, though, occur before the patient reaches the hospital. And about 3/4 of those patients who arrive at the hospital will actually die within the first 4 hours, with about 1/4 of those having actual survivable injuries. But they usually quickly succumb to secondary complications. One of the biggest complications, about 10% of patients actually have the complication of hypothermia. And that's regardless of the time of year. So how does that impact our patients? Well, we all know we've been cold. We know that we start shivering, right? That's our body's way of generating heat. And so when we start shivering, what's happening behind the scenes? Or our skeletal muscles actually increase O2 consumption. And some studies state as little as 40%. Other studies say as high as 400% increase in overall demand. That high metabolic demand, though, it actually causes other organs to start developing ischemic processes. And that's what starts breaking down these other areas and starts affecting these other areas. By the time that hypothermia actually develops, though, we have to remember the energy reserves in our body are often depleted, and we're not able to generate the heat needed. So we start showing clinical signs of decompensation or exhaustion. When we look at really the big picture of hypothermia, though, we got to remember it affects a lot of things that we have to have in play during these traumatic injuries. Got to remember, hypothermia interfaces with the clotting mechanisms. And if we are hemorrhaging, whether that is externally or internally, and those clotting mechanisms are now disrupted, we now have disruption of those platelet functions. And so any of those chemical reactions that are ultimately producing the protein strands necessary to build clots are now suppressed. This also will start suppressing our immune system. And so that is just a small fraction of what temperature regulation does within our body. Let's look at a case study and kind of think about this more broad. Let's imagine we have a 28-year-old male. Actual body weight is approximately 100 kilos, hit by a car at 45 to 50 miles an hour per bystanders. First responders are on scene. They do have a blood pressure currently of 88/62, pulse rate of right around 130, and they have an end-tidal CO2 of 22. So let's break that down. Number one, anytime you have a tachycardic heart rate in trauma, anything 130 or greater, we know is decompensated shock. So that's always a red flag. Always want to evaluate shock index. Can't say that enough. Shock index really is such an important number. We know that we're utilizing shock index now to guide our ketamine dosing. And so when we evaluate a shock index, we know we're going to take the pulse rate. We're going to divide our systolic into our pulse rate. So 130 divided by 88, and that gives us a shock index of 1.4. Anything greater than 0.9 is significant. Means that this patient likely will not do well, higher mortality. You look at that blood pressure though, and you say 88/62, hypotensive, looks crappy. But if you break that down and you actually calculate the MAP, that's actually a MAP of 70. So 28-year-old probably doesn't have hypertensive etiology. Doesn't mean that that's not in play, but I would say that a MAP with this person of 70 for just multi-systems trauma is probably pretty good, right? And we'll talk about more about permissive hypotension, or hey, do we need to bring that MAP up to 90 if this is also a traumatic brain injury patient? Continuing with your exam, you evaluate pupils. Pupils are 3 and bilaterally reactive, although sluggish. You determine that this patient does need advanced airway management. You listen to lung sounds prior to and during airway assessment. You notice he has absent breath sounds on the right, coarse breath sounds on the left. So anytime you have complete absent breath sounds, that is always going to be looked at as tension pneumo. You would definitely take care of that prior to advanced airway management. Manage his airway with BLS maneuvers with passive oxygenation prior, but you definitely need to perform chest decompression or finger thoracotomy, whatever's within your guideline. Remember, finger thoracotomy, chest tube placement, pretty easy, right? We know our 4th, 5th intercostal space, and we're going to go anterior axillary line. But what we often forget is needle decompression, whether you're using a 12 gauge, 3 1/4 inch standard angiocath, or you're using, let's say, North American Rescue's spear needle. We have to think about where is going to be the best location to give you success. And we know that the studies definitely have shown that the standard anterior second intercostal space actually has a really high failure rate of about 38%. And really the lowest failure rate was that 4th, 5th intercostal space, anterior axillary line. So definitely utilize that anterior location as much as possible. Also remember, if you do have to go the anterior chest, remember the clavicle does not just end in that small little window that we often look at. The clavicle goes from that angle of Lewis all the way over to that AC joint. And so oftentimes when you teach this and you see this in a cadaver lab setting, we see students going way too medial. And so we need to make sure that we're outside where those core structures are not likely to be injured. At this point, we've performed needle decompression. Coarse lung sounds on the left will continue to monitor, but we need to perform rapid sequence intubation, or what we always refer to as resuscitative sequence intubation. Remember, it's about slowing down, resuscitating, using good airway assessment. Heaven criteria is a great way to do that. We have a shock index of 1.4. This patient definitely needs to have a lower ketamine dose, and I would lower that down to 1 milligram per kilo. Rocuronium, I would dose this anywhere between 1.2 to 1.5 milligrams per kilo. and then perform your intubation. So we'll say you have successful intubation with a 7.5 ET tube. You have good end-tidal CO2 waveform capnography. Post-intubation, you've secured this with a commercial device, and you've got continuous monitoring with end-tidal CO2. At this point, we've got to start thinking about these other injuries. And all of this, guys, is getting us to the point where we got to make the determination. Do we need to give fluid? Do you have blood products with you? How are we going to manage that resuscitation? Does this patient need to be resuscitated? And, this is a podcast where we're focusing on warm fluids in resuscitation. I'm using a case study related to trauma, but remember, we have sepsis patients, you have burn patients, you have lots of patients that could need fluid. And so we have to think about this from just a wide angle. What types of patients would need larger volumes of fluid that could be susceptible to hypothermia? If we go back to this patient hit by a car 45 to 50 miles an hour, got to think about those core areas. And so I always think about, number one, our pelvis. Remember, if you have an open book pelvic fracture, sometimes that is hard to identify. And so always think about this as it's best to prophylactically treat any potential multi-systems trauma patient with a pelvic binder. Let alone this patient has a vertical shear pelvic fracture, which is most often seen in patients that are in head-on accidents. Maybe they fall from a high location and land on their feet. But that doesn't mean that a patient like this hit by a car could not have those catastrophic injuries. The big thing to remember is vertical shear always makes us remember that you could bleed out our entire blood volume. And a lot of these patients end up in traumatic arrest somewhere in that resuscitation time period. Next, I'm going to always think about what are we seeing in the chest. We've dealt with a tension pneumo, but could we have a hemothorax? And so would finger thoracotomy be a better option? Would chest tube placement be a better option in this point? That comes back to just remembering that we can bleed a lot of volume, not only out of our pelvis, but also into our chest cavity. What's the rule? Remember, if we're actually placing a chest tube, one of the rules that's often, I think, missed in standard education is, do you ever clamp a chest tube? And the common answer I get when I'm teaching is never. And that is true, but not true. When we place a chest tube on initial insertion, whether this is to drain a pulmonary effusion or you have a pretty large hemothorax, once you've placed that chest tube and you get 1,500 cc's out, that is when you clamp a chest tube. I've heard other people say 1,000, 1,200. The literature all agrees it's 1,500 cc's. And the real big issue here is the potential for reinflation or re-expansion pulmonary edema. Just pulling off all that volume quickly allows that lung to reinflate, and often you'll have that secondary pulmonary edema that happens. It could be 30 minutes. A lot of times it's a couple hours afterwards, and now you're dealing with a secondary problem. So again, be cognizant that's only on initial insertion. What about just standard hemorrhage? Not just the hemorrhage that we would see outwardly, right? Not a lot of these trauma patients that we have massive external hemorrhage, right? If you think about the patients that you have, whether you are looking at blunt or penetrating trauma, yeah, you do have patients out there that might have a femoral lack or injury or a brachial injury. Those are catastrophic injuries. Those are where we have to be good about understanding that a femoral artery is basically the size of a 6 to 6.5 ET tube. I mean, that is huge. Brachial, you could say 5.5, maybe 6 in a larger individual. And so either of those injury patterns are going to be catastrophic. We got to place a lot of pressure on the groin. You can use your knee, put your knee in somebody's groin and really compress. I mean, that is probably going to be a life-saving maneuver or procedure in those examples. Can't really get a tourniquet if it's that high, but always try. What we're talking about is, do you see patients decompensating and they have no visible hemorrhage? Again, think about those core compartments. Think about your chest. Think about Morrison's pouch. Think about obviously your core organs, your liver and your spleen, with your spleen being the more common organ being affected. And then what about your pelvis? Again, be cognizant that really any level 1 trauma patient should be assumed to have a pelvic injury, and prophylactic therapy of a pelvic binder should always be. All this leads us down the road of understanding our trauma diamond. If we are looking at this from the trauma patient standpoint, the trauma triad, that's what we used to always focus on. The trauma diamond has the addition of hypocalcemia. Really, this talk is focusing on us controlling the hypothermia aspect. And really, when you start looking at the trauma diamond and you look at the acidemia, well, the acidemia a lot of times is because of the massive hemorrhage, but the hypothermia really is the catalyst for a lot of problems, because we know that the hypothermia leads to increased O2 consumption because of the whole skeletal muscle attempting to generate energy. And we said 40 to 400% increase in overall demand, an increase in metabolic demand. All of that also plays into how does this manifest to our ability to clot and the coagulation pathways that are in play to hopefully attempt to keep us from hemorrhaging. What I want to talk about really is, can life-threatening hypothermia, can that be an iatrogenic cause? How many times do we cause that as providers? I think this talk really is a reminder that whether we're giving cold fluids or you're not covering your patients with warm blankets in the summertime, we're really, really missing the boat. And it's easy to forget, again, based on our environmental response to working on scenes and these long extrications and being in these hot aircrafts. We're soaked in sweat. We're so hot. The last thing that we're thinking about is that our patients are cold. So how do we deal with that? How do we also deal with that when it comes to making sure that we're treating the patient based on current literature? What do I mean? Well, remember, trauma patients, we want to think about permissive hypotension. And really, that target number is a map of 60. I do know that some trauma centers are being a little bit more aggressive based on these younger individuals coming in with penetrating trauma, no other comorbids. They often will bring that map down to 50 just to get them to the OR. But for pre-hospital medicine, we know that that 60 number is the target. So how do we maintain that? And then I'm going to add this caveat. How do we maintain a map that is going to be sufficient to perfuse the brain? Got to always think about multisystems trauma in conjunction with traumatic brain injury is a completely different elephant in the room, right? We can't think about permissive hypotension any longer. And we know that a cerebral perfusion pressure of 70 is our target. We have to get there by giving a map, or targeting a map, I should say, of at least 90 in that adult patient. We always assume that somebody's ICP with TBI is a minimum of 20. That's a good, nice round number. We get that because we know a normal ICP for you and I is 0 to 15. Raise that up to 20, nice round number. I've talked to some neurosurgeons that say probably more likely 30 in really these severe TBI patients. But I think for just easy math and to target a number, a ICP assumption of 20 is better. And so it's MAP minus ICP equals a cerebral perfusion pressure. And that's where we get a target of 90 minus that 20 gives us a cerebral perfusion pressure of 70. So meaning that we have to always think about protecting the brain. The brain comes first, everything else comes next. So how do we do that? How do we do that? Well, often, again, it comes down to we're doing that with fluids. I think the thing that makes this a little difficult is thinking about, well, a lot of places have gone to having the ability of giving either packed red blood cells, fresh plasma, or some have gone all the way to whole blood products. And we know that those blood products are held, anywhere between 2 and 6 degrees Celsius. And so they have to be warmed. And we have flash warming devices that are used to increase that temperature. That is completely simple, easy, and I'm really not going to focus a lot about that. What about all these EMS agencies or these flight companies out there that have not gone to the point of gaining blood product approval? Maybe it's based on medical direction, maybe it's based on cost, maybe it's based on access. Regardless, these agencies out there don't have those capabilities. The one thing they do have is fluids, whether that's normal saline or LR. And the thing that I see over and over and over is we are not good, and I put myself in that same category. Are we good at making sure that we have all of our fluids in a warming device? Again, it is completely different if you have blood products and you are using these flash warmers. What are we doing with standard saline and LR? Despite the target numbers, MAPS of 60 or MAPS of 90 in TBI patients, we're still giving volume. Whether you're giving 250 cc's, 500 cc's, or a liter, you're giving cold fluids oftentimes. What I see, and I guarantee you guys have experienced this or done this, is in the wintertime, it's easy. We often threw some normal saline bags up on the dashboard. And let's let the heater run hot air over the bags, but I guarantee you we're not raising the temperature high enough to meet those body demands. And so it comes back to, again, are we understanding the impact of giving fluids to these patients? Are you going to give cold fluids or are you going to give warm fluids? And how do we do that? One great way is obviously a warming device. And there's, great warming devices out there. I know ones I've used in the past that I think have been great is the Thomas Transport Packs. Those are excellent devices that seem to do a good job. You can put, 3 to 4 liter bags in these cases, and, they maintain a certain temperature, keep them plugged in. And really the cost is not exponential. The cost relative to what it does and what it accomplishes, I think, is well worth it. Obviously, every department out there is going to have to evaluate the need, cost benefit analysis. But I think the thing that we have to remember is we don't really see the impact of what we do in the pre-hospital setting. A lot of these patients, as I said in the very beginning of this podcast, ended up having survivable injuries, but die from secondary complications. A lot of those complications are started from hypothermia. There's lots and lots of studies out there, guys, that really highlight how hypothermia, not only in trauma, but just in patients in general, lead to this vicious cycle that causes these patients to spiral out of control. And so it's important to treat hypothermia early, start it immediately, and really comes down to prevention. Don't allow these patients to cool down. Keep them warm. Again, remembering that we just came out of 2 major 20-year military conflicts, and there's lots of data out there from the military side where ambient temperatures of 120, 130 in the Middle East, these soldiers were being delivered to these battle hospitals hypothermic. And so, again, ambient temperatures aside, has nothing to do with if a patient is going to be warm or cold. Got to make sure that we're preventing that cooling, not only by making sure those warm fluids are utilized, but also thinking about if we do strip their clothes off, are we covering them up? Here's another study, again, hypothermia as a predictor for mortality in trauma patients at admittance to the ICU. When you look at the results, 953 total patients in this study, 354 of those patients actually had hypothermia upon admission, which equates to 37%. And when they looked at these, they subcategorized them into normothermic or hypothermic. And they found that the hypothermic group was associated with a much higher mortality at the 24-hour and 28-day mark. The paper concluded that trauma patients that were admitted to the ICU may be at a higher risk for mortality if they arrived hypothermic and they had associated other injury patterns. Of note, coagulopathic, they had severe injuries or also had traumatic brain injury, and the mortality actually increased as the age increased. And so again, it comes back to the hypothermia, right? That is the first part of this whole triad that we definitely can make a big difference in. As I alluded to, when we look at the military, we think about what we learn from military conflicts and from the military in general. Hypothermia definitely is the key contributor to the triad of death, which is now, again, as I said, the trauma diamond. It's about understanding that if your patient has wet clothing, remove them, monitor their temperature. But the key is warm resuscitation fluid. Blood products need to be between 38 and 42 degrees with flow rates that exceed 150 mils per minute. So meaning that we have to do a good job in keeping these patients warm. And that brings us back to the realization that the greatest contributor to hypothermia really is room temperature fluids and packed red blood cells. I think we've done a good job in the industry making sure that there are safeguards in place to make sure packed red blood cells, whole blood, etc. is flash warmed to that temperature that is required to maintain that normal thermia. It's the normal saline, the LR, and these other fluids that we give in these resuscitation phases. When you look at EMS, resuscitation happens on the side of the road, happens in a ditch. As you know, we often remove clothing, so are we being good about making sure we have warm blankets? One of the things I always look at when I go into a base to visit is, do they have the aircraft blanket on the gurney? Whether it is summertime or wintertime, that nice thick aircraft blanket that's insulated should always be on the gurney. It should be used no matter what time of year it is, because these patients are susceptible to cooling off so quickly. How many times have you taken a patient into a trauma center? And there's lots of different trauma centers out there, but there's some trauma centers that definitely have the heat going. You walk in, you can definitely tell that they have the heat on. They remove all the clothing immediately, but they immediately cover them up. And I've been in other trauma centers where, man, you are stripped down naked and that patient is laying there for everybody to see. There's no blankets on. The room is not warm. It's not cold, but obviously these patients are freezing to death. All of these little things that we do really make a difference in the long run. So coming back to that, we got to remember, what are those ancillary areas of our body? What mechanisms are affected with hypothermia? Well, remember, to maintain normal thermia requires ATP. And so if we are allowing our patients to become cold, what happens? They start shivering. They start burning through those glycogen stores. And our glycogen stores really are the catalyst to producing ATP. That's the whole process of gluconeogenesis, to convert to glucose, which converts to pyruvate, goes through the whole cascade of events that ultimately ends up in the electron transport chain where we form ATP. Lots of other things that we could get into in regards to ATP production that's so essential. We have the consumption of hydrogen ions. We have the breakdown of oxygen into water, right? We know there's so many facets there. All of that stuff becomes affected by simply allowing our patients to become hypothermic. We said that the skeletal muscles, the increase in O2 demand skyrockets up to 400%. Remember, there's two big caveats to oxygen delivery. Number one, we have to have cardiac output. Number two, we have to have the content of oxygen in our arterial blood. And what carries that content is hemoglobin. So if we have a trauma patient that's hemorrhaging out, again, it doesn't mean it's spilling on the pavement. We know that these patients can bleed out internally. We've talked about those three main compartments, let alone long bone injuries and injuries such as that, let alone long bone injuries. But just looking at the delivery of oxygen in general and hypemic hypoxia, we have to remember not only are we probably facing a patient that has depletion in O2 carrying capacity, but they also now have a higher overall demand. I always talk about this in our critical care courses, and I relate this to really debt to income ratio, that the average adult patient delivers about 550 mils of oxygen every minute. And that's going to be, again, a calculation based on body surface area, or body mass index, I should say. And the average adult consumes about 20% of that. And so it would be like you making about $550 a minute and you spending about $120 to $150 a minute. That would give you a debt to income ratio of about 20%. But as we know, if you went and tried to go get a loan, the higher your debt to income ratio goes, the more maybe that bank is going to start looking at other areas for approval. And your body is very, very similar, right? We do really, really well. We have plenty of O2 reserves carried within our hemoglobin. Hemoglobin really is that key area, and I always call that your savings account. Well, once we start encroaching on that 30%, maybe even up to 40%, that's where things get really serious and we start consuming way too much. Well, you now couple that with the drop in O2 carrying capacity, and you have a big, big problem. And that's why trauma patients in general really go downhill quick, because not only are you burning through so many oxygen stores, but your ability to carry oxygen to replenish those stores is now depleted. As we said, the coagulation pathway is disrupted. I think the thing to remember is a drop in pH from 7.4 to 7.0 decreases the coagulation cascade ability to clot by 55 to 70% based on current literature. That's a huge difference. So why does that happen? Well, coagulation is dependent on temperature, which causes platelet sequestration. The big thing with this podcast is just to remind us that utilizing simple warming devices can really make a huge difference. I definitely would say, in my own experience, that I probably haven't done a good job, and I would say more on the EMS side, where we didn't always have warming devices. Are you being cognizant of what you're infusing into your patients? Fluids should always be placed in a warming environment, despite any warm or hot ambient environments. Again, it's really easy to recognize that freezing outside, it's negative temperatures in some of the areas of the US. And there are studies that I could have highlighted, and I'll put these links in the show notes, where there's a translation of the fluid temperature based on the environment that you're actually working in. Despite maybe having the ambulance running, operating, it's not sitting there running all the time. So remember, warm your patients. If you strip the clothes off, cover them up. Give warm fluids. Always warm blood products. Lastly, heat loss drives that lethal diamond. And remember, it all starts with that hypothermia that really manifests into affecting multiple organ systems. And that's where a lot of these patients that have survivable injuries end up having these secondary failures and end up passing away. Hopefully this podcast was just a reminder that despite maybe our experience, that it's easy to get complacent, easy to forget that doing these little things like this does make a huge difference in the long run. As always, if you have any questions, please email me, eric.bauer@FlightBridgeED.com.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.